So we are going to commence the lecture now. So we'll start with taking focus history in OSCE stations. Now, you should know that when you are asked to take a focused history is different from taking a detailed history. There is difference between a detailed history and a focused history, which usually you are asked in OSCE stations. In OSCE stations, you are asked to take a focused history. Now, when you are asked to take a focused history, what is expected of you? You should know that taking a focused history, you are asked to take a history on the subject matter that is being asked. You are not supposed to digress to so many unimportant details of the question that is being asked. So there's a difference between detailed history and focused history. So we are going to see some examples on an OSCE station on how to take a focused history. Okay. Now, this is a template on how to take a focused history in an OSCE station. The first item of a focused history is to create rapport. Now, creating rapport is all about building trust between you and patients. And on the marking scheme, there are 3 items that are looked out for when you are creating rapport. You greet the patient, you introduce yourself, and you seek permission. Okay? Those are the 3 items in creating rapport. You do not just go and start asking patients questions. Rather, you have to build trust between you and the patient. The next item is the biodata. Of course, Nastroma, name, age, sex, tribe, religion, occupation, marital status, and address. Of course, you are not going to be asking the patient of his sex. Now, presenting complaint and the duration of the presenting complaint. Don't just ask the patient on what brought patient to the hospital. You must ask a patient for how long. Because if you just ask the patient of the presenting complaint, you get half of the mark. You must ask for how long. Okay? Next is the history of the presenting complaint, which you will focus on 5 C's. You will focus on 5 C's. Detail on the complaints. The cause of the complaint, meaning the progression of that complaint. The cause in terms of etiology or risk factors. The complications patient developed and the care the patient received. Now, these are the areas you will pay attention to. Sometimes you could ask complications before you ask the etiology, depending on the nature of the presentation. If a patient is already presenting with a complication, so it's more important for you to rule out other complications before going to history of risk factors or etiology. Past medical history, okay? Past medical and surgical history. Now, systemic review is not too relevant in taking a focus history. Systemic review is not too relevant. You should know that the aim of systemic review is to look for concomitant disease in the patient. However, in a focused history, there is a way you will abbreviate the systemic review, which we are going to see shortly. Now, what are the components of rapport in a focused history? You greet the patient, you introduce yourself, and you seek for permission. You should know that in OSCE, you don't waste too much of time. Good afternoon, ma. My name is Dr. Bashir Yunus. For the purpose of these exams, I'm asked to take a history of breast lump from you. May I proceed? So the examiner will give you a full mark. 1 for greeting, 2 for introducing yourself, and 3 for seeking permission to proceed. You have built a trust between you and the patient because the patient is now aware of the person is giving information to. The biodata, of course, has its own mark. You have to ask the patient's name, age, okay, tribe, occupation, marital status, and the address of the patient. Now, the presenting complaint in the question on the OSCE station, you might be told that a patient presented with jaundice. Take a focused history. Don't assume because the question already told you that the patient presented with jaundice, you will not ask the presenting complaint. You must ask, what brought you to the hospital? Okay, that is a question that is guiding you to interact with your patient. So you must ask the patient the question, okay? What brought you to the hospital? The patient responds, yellowish discoloration of the eyes. You now ask for how long. If you ask a presenting complaint without asking the duration, the mark for that section is incomplete. Okay? Then you now move to the next step, which is the history of presenting complaint. From the question we saw initially, just for example, you are asked to take a history, a focused history from a woman, a 45-year-old woman presenting with a left breast lump. In the history of presenting complaint, you must ask for the 5 C's. The cause, complications, and care the patient received. How was the lump noticed? Okay, it is important because some patients, it is pain that draws the attention of the patient to the lump, while in others, it is during self-examination. When it is pain, you know most likely it is an inflammatory lesion, okay? When it is just noticed during self-examination while taking her bath, you know it's likely non-inflammatory, okay? The initial size is very important because you want to know the progression over time. You ask the patient, what is the initial size? Okay? What is the current size? Has this lump ever disappeared? Is there lump elsewhere in the body? Now, you should know that anytime you are taking history of a symptom, you must exhaust that symptom before going to related symptoms. If you notice, while I'm asking history of breast lump, my next question was not whether there was associated pain or nipple discharge. No, because those are what related symptoms. So you have to exhaust the swelling first, which is the initial size, okay, the current size, whether it has ever disappeared or if there is lump elsewhere in the body. But precisely, you are asking for lump in the armpits, the axilla, the neck, or the head of the patient, to be precise, okay? So you have to ask of the initial, how it was noticed, okay? The initial size, the current size, whether it disappeared before, lump elsewhere, whether the neck of the patient, the armpit, or the head of the patient. Then the related symptoms, like pain. Is there associated pain? Is there nipple discharge? Is there skin change? Are there skin changes? You ask for that, okay? Now, you go to etiology. Now, you ask for all those histories suggesting prolonged exposure to estrogen, okay? Like early menopause, okay? Early menarche, late menopause, use of estrogen-containing oral contraceptives, okay? Use of hormone replacement therapy, nulliparity, duration of breastfeeding, all those factors that are related to prolonged exposure to estrogen, okay? So, exposure to radiation, family history of breast cancer, and so on. So you ask for history of etiology, all the risk factors for that particular condition. You ask. If you have your question, note it down. After the lecture, I'll respond to your question, okay? So that we don't have so much distractions and waste of time. So you ask for complications. Now, when you are asking for complication, you should know that complications are either local, locoregional, or systemic. Local complications are the complications that are related to the organ in question. Locoregional complication when they have affected the adjacent organ. And systemic complication is when they have spread to a distant site. For example, You are talking of an anterior neck swelling, for example. Okay. You know, the locoregional complication will be when it is compressing on the trachea, compressing on the esophagus, pressure symptoms giving dysphagia and maybe difficulty in breathing. If you are talking about breasts, okay, when there is local infiltration, okay, it has involved the skin, causing ulceration, spontaneous ulceration. It has invaded the chest wall. It has invaded the axilla, causing ipsilateral upper limb swelling. Okay, when it spread to the chest, causing difficulty in breathing, to the bone, causing bone pain, all those are systemic manifestation. When it spreads to the liver, causing jaundice. The care the patient received. Since you presented to the hospital, what has been done, the investigations that were done, the treatments the patient received, was there any improvement, okay, on receiving treatment? Were there side effects of the treatment received? So, you see, if you are focused, you will hardly miss any aspect on a focused history because you have 3 to 5 minutes on a station. The past medical history, you will talk about the history of hypertension, diabetes mellitus, asthma, previous surgeries, and blood transfusions. Now, in systemic review, you want to briefly look at some systems to know if there are concomitant disease, and you go through all the systems. Usually there's a manner you can ask this in form of a yes or no question. You can tell the patient, I would like to ask you some questions. You answer yes or no if they are present. Then you go system by system. And usually this is after you have taken a detailed history of presenting complaint. You still have time. Of course, you are going to ask all the systems. And don't forget, after the systemic review, you are going to thank your patient. So I'm going to take an example of a marking scheme in an exams. Then you now see how you answer the question on the station. Now, a question says, take a focused history from a 45-year-old man who presented with bleeding per rectum. Okay, you want to take a focused history on hematochezia. Now, let me draw your attention. Whenever you are taking history of bleeding from anywhere, whether hematochezia, whether hematemesis, hematuria, or whatsoever, don't forget you must exhaust the bleeding in question before you go to associated symptoms. Okay, now this is a marking scheme of hematochezia and how the marks are distributed. If you notice, there are 3 columns: good, fair, poor, or not done. When you ask all the questions, you get your full mark. When you ask fairly, you will get half of the mark in that section. If you ask poorly or you do not ask, you will get 0 in that section. Now, you follow the steps. The first step is to create rapport with the patient, which is you greet the patient, you introduce yourself. My name is so and so, and for the purpose of these exams, I was asked to take a history of bleeding from you. May I proceed? Okay, you get your full mark. The next is the biodata. Okay, you ask all the components of your biodata. Then the rapport and the biodata each may carry 1 mark. Okay, rapport 1 mark, biodata 1 mark. Then the presenting complaint and the duration. What are your complaints or what brought you to the hospital? Don't make a mistake of saying because you are told that the patients have hematochezia. She's a market woman, for example. It's a market man. You now say, I was told you have hematochezia. When did it start? The patient will just be looking at you. What is this man talking about? Okay? So you have to ask the question, what brought you to the hospital? For how long is this complaint? Okay? Now, don't forget, if you come to the history of presenting complaint, you have to ask questions regarding the complaint itself before you go to associated symptoms. Don't forget. The onset, okay? Anytime you have a symptom, don't forget, those symptoms start in 2 ways. It could either be insidious in onset or it could be sudden in onset. It might be gradual over time. It might be sudden in onset. You ask for the nature of the bleeding. Is it a bright red blood or is it an altered blood? You ask for the quantity of the bleeding. The simulators, all the patients are already told how to quantify the blood. You ask for the quantity in volume. Some may tell you it's about the sachets, the quantity is about the sachet of pure water or a cup or whatsoever they are told to answer with. Are there associated clot? Anytime you are asking of bleeding, don't forget, you must ask for associated clot, because clots signifies severity of bleeding. A clot that is about the size of a clenched fist is roughly about 500 mils. You see? You want to ask for the frequency. How many episodes have patients had since the onset? Okay, 2 episodes, 3 episodes, interval between the episode. What was the last episode? You can see, since I started, I'm still asking on what the bleeding. The next thing you want to ask for, associated symptoms. Associated symptoms. Now you can see dizziness, palpitations, fainting, easy fatigability are all symptoms of what? Anemia. Okay? So these are symptoms of what? Anemia. Now, melena, you ask for passage of blackish stool, okay, hematemesis, okay, because these are local problems. It might be an upper GI bleeding. By the way, upper GI bleeding is the commonest cause of lower GI bleeding. Okay. So you ask for what? Easy bruisability, ruling out a systemic cause of that bleeding. Now, you want to ask for jaundice because it might be related to the liver. Even the upper GI bleeding might be related to chronic liver disease with raised portal hypertension. Now, you want to ask relationship of that bleeding with the stool. Is it mixed with the stool? Does it coat the surface of the stool, or does it come after the stool? All these are important. You want to ask if there is associated anal protrusion. You want to ask if there is associated anal pain. Okay? You want to ask if there is change in bowel habits. You want to ask if patients have tenesmus, weight loss, anorexia. You can see all these symptoms are symptoms that are related to bleeding in the gastrointestinal tract. Now, what care or intervention did the patient receive? Any blood transfusion? Since they presented, what was done? What were the investigations done? What were the medications given? Any infusion given? Past medical history is important, okay? Where you ask for systemic problems as well as previous surgery. Now, history of drug intake. Drug intake is very important in patients bleeding anywhere, whether in the GI or systemic in origin. They may tell you they are taking NSAID, they may tell you they are on steroid, they may tell you they are on anticoagulants. Okay, you ask for family history of the condition, you ask for social history, like smoking and alcohol ingestion. Now, don't forget to thank the patient. Don't forget to thank the patient. Now, you should know that in your OSCE, when you are orderly in asking question, you have an extra mark. When you are properly dressed, you have an extra mark. Okay, so after this is a focus history. If you have time, you ask for systemic review before thanking the patient. Okay, but focus history is history on the subject matter. You don't deviate into irrelevant things like any difficulty in passing urine, any hesitancy, any convulsion. All those things are not, they are totally irrelevant. Those are in detailed history. When you see focused history, you just focus on the subject matter. If you have more time, you have exhausted your marking scheme, you can ask all those ones. So before we move into the picture test, I'm going to unmute you, and if you have questions, we will talk about the questions, then we proceed. So if you have any question, you can unmute yourself, you ask the question, then we proceed.
Good afternoon, good evening, sir. I have a question.
Okay, you can go ahead with your question.
So I've been told that regarding my social, if I'm trying to ask to find out the etiology, I cannot, if I've asked about, for example, in the case of breast lump, I have asked about, I'm trying to find, to assess the risk factors, I have to ask about smoking. And so if I have asked about smoking in the etiology, I have to repeat it when I come to, after past medical history, drug history, I have to redo it all over again. And also, if I have exhausted the system and the presenting complaint, I also have to repeat it again in systemic review. Is that how it is done, or?
That is a good question. Now, in history taking, avoid repetition, please. There are some questions that will feature as risk factors because, as we all know, smoking and alcohol are in the social history. But if the pathology in question, smoking and alcohol are part of the risk factors, so you ask them during history of risk factors. You don't ask them again in the social history. So you want to avoid repetition as much as possible because you have limited time, okay? And of course, you don't want to be repeating so many words, you cause confusion. So the proper way is when you ask a question as a history of etiology, that social history is already a risk factor, so you don't need to ask it again in the social history. You don't need to ask the question again in the systemic review. If you already asked a complication, okay, you don't need to ask that complication again in the systemic review because it has already featured as a complication. I hope that is clear.
Yes, thank you, sir.
You are welcome. Please, any other question before we proceed?
Thank you very much, sir.
You're welcome.
Yes. Sir, my question is during the creating rapport, sir.
Yes.
You say you are introducing your name. Sir, are you going to mention our names during the exam, or are we going to say I'm a candidate for this exam? I want more clarification, sir. Thank you, sir.
Okay. You see, if you mention your name, there's no problem with that. If you say my name is so and so, and I'm a candidate for these exams, I was asked to take a detailed history from you, there's no problem with that. Okay?
Oh, okay, sir.
Yes.
Thank you, sir.
Yes, you're welcome. Any other question before we proceed? Okay, I believe we don't have question. There's a question on the chat. Okay, I think it's the same question we asked. Okay. So the next part of the lecture is going to be on picture test tutorials. Now, in your picture test, usually they come in two ways. They come as a multiple choice question and they may come as essay question. Usually the undergraduate MBBS, most of them come as multiple choice questions. For pre-MDCN exams, multiple choice questions. Postgraduate exams, they may come as essay, they may come as multiple choice question. Okay, this first question says, mention the boundaries within which the instrument can be safely passed. This is a chest tube, okay? You are asked to mention the boundary through which you can pass a chest tube, okay? Now, you know, chest tube is passed, okay, for a patient who met the indication, of course, when there is a collection within the pleural cavity, whether blood, okay, fluid, air, okay, or maybe during a post-thoracotomy period, you want to pass a chest tube for prophylaxis. Now, after meeting the indication, you follow all the steps, then you pass a chest tube through a triangle of safety, okay? So you are asked now to mention the boundaries of the triangle of safety. The next question is mention 6 lethal. Mention the lethal 6 of deadly dozen. Okay. Now, the triangle of safety is a triangle in the lateral part of the chest. Okay. The apex being the tip of the axilla. For an abducted arm, the anterior margin of that triangle or the anterior border of that triangle is the anterior axillary line, which is the lateral margin of the pectoralis major muscle. The posterior border is the mid-axillary line, which is the anterior border of the latissimus dorsi muscle. Then the inferior border is the 5th intercostal space or the upper border of the 6th rib. These form the triangle of safety. It is a triangle that is the thinnest part of the chest wall where you are likely going to encounter neuromuscular bundle, okay? Where you are unlikely going to injure any neuromuscular structure there. Usually you can pass the chest tube through any space within this boundary, usually in the 4th intercostal space in trauma, okay? And you know, when you are passing a chest tube, you should know that passing a chest tube, you go through the rib, the upper border of the lower rib in the intercostal space. The upper border of the lower rib in that intercostal space, because neurovascular bundle, the intercostal vessels and nerves are located in the lower border of the rib. So if you are passing a chest tube, it should go through the upper border of that rib, of the lower rib in the intercostal space you are passing the tube. Okay, so the first question on the borders or the boundaries of the triangle of safety: anteriorly is the anterior axillary line, posteriorly is the mid axillary line, and inferiorly is the 5th intercostal space or the upper border of the 6th rib. Passing a chest tube is called chest tube thoracostomy. Thoracostomy, when you are connecting any cavity to the skin, okay? Colostomy, colon and skin. Thoracostomy, okay? Colostomy, ileostomy, you are connecting to the skin. So this is called chest tube thoracostomy. Now, the next question is to mention the lethal 6 of the deadly dozens. Now, you should know the deadly dozens are major thoracic injuries. And there are the lethal 6 and the hidden 6. The lethal 6 are immediate life-threatening injuries that require evaluation and treatment during the primary survey. The lethal 6 must be managed during the primary survey to save the life of the patient. The hidden 6 are potentially life-threatening injuries that should be detected during the secondary survey. Now, airway obstruction is number 1 in the lethal 6, airway obstruction. Because if airway is completely obstructed, patients have only 4 minutes to survive an irreversible hypoxic brain damage. Patients have only 4 minutes to survive hypoxic irreversible brain damage. That's why the airway is number 1, because the lung reserve capacity is 1 liter and the brain consumes 250 mils of oxygen per minute. So if there is complete airway obstruction, within 4 minutes, the brain have consumed the lung reserve volume and it will suffer an irreversible hypoxic brain injury. Tension pneumothorax, cardiac tamponade, open pneumothorax, massive hemothorax, and flail chests. These are the lethal 6. The hidden 6 are thoracic aortic disruption, tracheobronchial disruption, myocardial contusion, traumatic diaphragmatic tear, esophageal disruption, and pulmonary contusion. Okay. The next question is, mention 4 precipitating factor of the condition. Now, this is an inguinoscrotal hernia. This is an inguinoscrotal hernia, okay? An inguinoscrotal hernia have precipitating factors, which are those factors that will cause increase in intra-abdominal pressure, and it will precipitate protrusion of the swelling. Okay, this, when you say precipitating factor of a hernia, is different from predisposing factor. Okay, there's a difference between predisposing factor and precipitating factor. Now, Precipitating factor are those factors that will increase intra-abdominal pressure, that will precipitate protrusion of the hernia. Okay, that will cause straining, like chronic cough, chronic constipation, bladder outlet obstruction. All this will lead to straining. There are some predisposing factors that are inherent in the patient. Okay, they are inherent in the patient, like connective tissue diseases, weakness of the anterior abdominal wall, aging of the patient. Okay, but other factors that will precipitate the hernia, like increased intra-abdominal pressure, pregnancy, intra-abdominal masses, ascites, and so on. Now, if you are asked precipitating factor or risk factors, just first mention all those that will cause increase in straining. Then you can mention the inherent ones. You see patient that is having chronic cough, okay? Patient that is having chronic constipation, patient having bladder outlet obstruction, patient that is having maybe intra-abdominal masses, ascites, pregnancy, and even obesity. Diabetes mellitus, connective tissue diseases, weakness of the anterior abdominal wall, all these are conditions that are inherent, that may be non-modifiable, okay? All these are predisposing factors. Now, what are the complications of the condition? Hernias, one, they could be irreducible. It's a complication, okay? Irreducible hernias are complicated hernias. It could be obstructed when there is impediment of the flow of the contents of the sac. There's obstruction. It's a complication. There's strangulation, which is impairment of the blood supply of the contents of that sac. It's a complication. There could be pressure necrosis. Pressure necrosis. Hernia may grow to a large size, exerting pressure on the overlying skin, and they may have pressure necrosis. Hernia may be complicated with what is termed loss of domain. Hernia with loss of domain, when most of the contents of the abdominal cavity have moved into the hernia sac, okay? That is loss of domain. You know, of course, while treating such hernias, you don't just return the contents into the abdominal cavity, because they will have increased intra-abdominal pressure, intra-abdominal compartment syndrome, okay? So don't forget the complication, irreversibility, obstruction, strangulation, pressure necrosis, loss of domain, okay? Mention 4 indications for treatment of the above condition. Now, you should know the most important indication that usually brings most of the patient to the hospital is cosmesis. Okay? Cosmesis. Most of the patient present because of cosmesis. 2, toxic symptoms. When they present with symptoms of toxicity, it's an indication for treatment. 3, pressure symptoms. When they exert pressure compressing on the adjacent structure. Okay? 4, malignant symptoms. Mention 5 relevant investigations in the management of the condition. Okay. One, you want to do a thyroid function test. Thyroid function test where you are assessing T3, T4, and thyroid stimulating hormone. You should know that T3 is the active form of the hormone, triiodothyronine. T4, tetraiodothyronine, is thyroxine. Most of the thyroxine, T4, are converted to the active form, which is the T3. So there's peripheral conversion of T4 to T3 because T3 is the active form. In hyperthyroidism, you have an elevated T3 and T4 and depressed or unrecordable TSH. In hypothyroidism, you have depressed T3, T4, and elevated TSH. In T3 toxicity, you have an elevated T3, normal T4, and reduced TSH. In T4 toxicity, T4 isolated T4 toxicity, you have elevated T4, normal T3, okay? You have normal or reduced TSH. And usually T4 is related to drug-induced thyrotoxicosis, okay? Now, number two, you want to do neck ultrasound scan. You want to do a high-resolution ultrasound scan of the neck, okay? You want to do a high-resolution ultrasound scan of the neck where you want to, number one, get an anatomical diagnosis. You want to define the origin of that swelling, okay? You want to confirm that, yes, this swelling is originating from the thyroid gland. Two, you want to note the nature of the swelling, whether it is cystic or it is solid. Three, you want to assess the lymph nodes, the cervical lymph nodes, whether they are enlarged. Four, you might want to do ultrasound guided fine needle aspiration cytology. So these are some of the reasons why you want to do an ultrasound scan of the neck. Number three, you want to do a neck X-ray. You want to do an AP view, anterior posterior view, and a lateral view. The anterior posterior view, you will see a soft tissue shadow. You will take note of trachea deviation. Okay, whether this trachea is centrally placed or it is deviated. You should note that when the gland, the left lobe, is enlarged, the trachea is deviated to the right side. When the right lobe is enlarged, most of the time the trachea will be deviated to the contralateral side. Now, anterior posterior view, one, you will see a soft tissue shadow. Two, you want to note the deviation, the positioning of the trachea. Three, you are looking for calcifications. There are two types of calcifications when you are examining the X-ray. They could have a stipple calcification, they could have a coarse calcification. Patients with stipple calcifications are usually seen in papillary thyroid cancers. Papillary thyroid cancers. On X-ray, you might see stipple calcifications. And those calcifications are representation of what is called Samoma bodies. Samoma bodies are pathognomonic for papillary thyroid cancers. And on X-ray, they appear as stipple calcifications. You might also see coarse calcification. You might also see a coarse calcification. Coarse calcification represents a long-standing goiter. Coarse calcification represents a long-standing goiter. Is it clear? Now, why do coarse calcification represent long-standing goiter? Because that is what is termed dystrophic calcification. Dystrophic calcification usually presents as coarse calcification because, as you know, the gland, they undergo proliferation and involution. Proliferation and involution. And there is calcium deposit on those dead tissue that have undergone necrosis. Okay, so they present as coarse calcification in long-standing goiter. So, soft tissue neck X-ray, AP, positioning of the trachea, soft tissue shadow, calcifications. Then the lateral view. The lateral view, you want to check for compression of the trachea. Compression of the trachea. You will see the AP view will not show you, but on the lateral view, you will see the patency of the lumen in relation to the goiter anteriorly. That is one. Two, you want to check for the cervical vertebra, whether there is cervical spondylosis, because the anesthetists are very keen. Because if you are intubating a patient for thyroidectomy, you have to do what? Hyperextend the neck to intubate. So the anesthetist actually needs the lateral neck X-ray, okay, to rule out cervical spondylosis. Now you might see loss of lordosis of the cervical spine. Number 4, you want to do laryngoscopy. Laryngoscopy is done for medico-legal reasons, preferably fiber optic flexible laryngoscopy. Traditionally, the indirect laryngoscopy is used where mirrors are used to assess the vocal cord. You want to assess the state of the vocal cord for medico-legal reasons. You want to see if there is a partial paralysis that is asymptomatic. You have to document that and inform the patient that the patient already have an asymptomatic unilateral recurring laryngeal nerve paralysis before the surgery, because your surgery might precipitate manifestation of the symptoms, which of course the patient have to be aware of that before the surgery, which might determine their consent for the surgery. So for medico-legal reasons, you want to assess the state of the vocal cord. Okay, so you do laryngoscopy, either flexible or indirect laryngoscopy. You want to do, there's what is called thyroid scan. This thyroid scan is using radioactive iodine. Radioactive iodine. Now, radioactive iodine 1, 2, 3. Iodine 1, 2, 3 is used for radioactive scan. It has a shorter half-life than iodine 131. Iodine 131 are used for radio ablation. They are used for treatment. They have a longer half-life. They completely ablate the gland and render patient hypothyroid. So the iodine 123 is the one that is used for investigations. And this is usually given orally and patient is isolated. Then you now use your gamma camera to read. How is it interpreted? When you see a gland that is hot, that means it is darker than the surrounding tissue. It means that gland is hyperthyroid. When you see a gland that is warm, okay, the color is the same with the surrounding tissue, and that is euthyroid. And when you see a gland that is cold, it is lighter than the surrounding tissue, and that is hypothyroid. And you should know that up to 10% of hypothyroid or cold glands are malignant. So when you see a cold gland, it's an indication for biopsy, looking for malignancy, okay? So we've mentioned how many? 1, 2, 3, 4, 5. Okay, there are several other tests. And one important, very important test is fine needle aspiration cytology. You want to define if the gland is benign or malignant, okay? For all thyroid lesions, you must do fine needle aspiration cytology for evaluation. You want to differentiate benign from malignant lesions, okay? And you have a system of reporting the fine needle aspiration cytology. Ty 1, 2, Ty 5 or 6. When you say Ty 1, okay, it is benign. Okay, you repeat the investigation, okay? Or non-conclusive, you have to repeat. Ty 2, it is benign, okay? Ty 3 is follicular neoplasm. And you know, there's a challenge of FNAC in differentiating follicular adenoma from follicular carcinoma. So for those, that's why it is called follicular neoplasm. Then type 4 is suspicious, type 5 is malignant, type 6 proven malignancy. Okay, so these are some relevant investigations. So if you are asked for relevant investigation, don't forget your thyroid function test. Don't forget the X-ray of the neck. Don't forget the indirect laryngoscopy. Don't forget the don't forget the neck X-ray. Don't forget the fine needle aspiration cytology. Okay, so what is the modality of evaluation of this condition called? Okay, what is the modality of evaluation of this condition called? Now, this is breast cancer. Now, evaluating breast cancer is via triple assessment. And triple assessment include clinical, radiological, and pathological or histological. So any patient that presents with breast lump, any patient who presents with breast lump, you must evaluate using the triple assessment. Number one is clinical. You have to take history and physical examination. Number two is radiological. For those patients that are less than 35 years, you do ultrasound scan of the breast. For those patients that are more than 35 years, you do mammography. Ultrasound scan is done in patients less than 35 years because of the breast is dense. It has more fibroglandular tissue, while in more than 35 years, they have more of fatty tissue. And you know, ultrasound scan is less sensitive in assessing fatty tissue. So you do mammography. And the system for reporting any breast imaging, whether ultrasound or mammography, is called BIRAD. Breast Imaging Reporting and Data System, BIRAD. Breast Imaging Reporting and Data System. And it is BIRAD 1 to 6. Now, the third modality is histological or pathological, where you do either FNAC initially or histology. So you must do triple assessment in evaluating any breast lesion. What are the components of this modality? That is what we mentioned. So you should know all the risk factors for breast cancer. What does this picture depict? What does the picture depict? Now, if you look at this, this is a chest radiograph. This is a chest radiograph. This is a chest radiograph of a patient that shows, okay, one, look at this. You can see there's a mediastinal shift here. Okay, there's a mediastinal shift. Here you can see there is collapse of the lung. This is the breast shadow. Don't think it's the lung. The lungs have collapsed on this side. So all this place you have air, because it is what? It is radio lucent, okay? Then you can see here you have the lung is being compressed on this side. So when you see a patient having chest X-ray, mediastinal shift to a contralateral side, and air collection in the opposite side, air collection in the affected side, that is usually a tension pneumothorax. Okay, that is a tension pneumothorax. Now, they said you should mention two abnormalities that are seen. One, you can see there's mediastinal shift. Two, there is pneumothorax on the affected side, and there's compression of the lungs on the contralateral side. Usually, this patient present with severe difficulty in breathing, inability to complete a sentence on a single breath. They have distended facial and neck veins with severe respiratory distress. So your immediate intervention is to pass a wide bore cannula. Your immediate intervention is to pass a wide bore cannula in the second intercostal space mid-clavicular line. Your second intervention is to pass a wide bore, your immediate intervention is to pass a wide bore cannula in the second intercostal space mid-clavicular line, okay? After passing that, you hear a hissing sound, a gush of air that immediately leaves that pleural space. Then afterwards, you now pass a chest tube. You now pass a chest tube. There will be a chest tube thoracostomy. There will be a chest tube thoracostomy passed. So the next question, what does the picture depict? Mention two abnormalities seen. What are the cardinal features of the condition? Okay, let me unmute so that we'll have some participants. So you can unmute yourself and participate. Okay, if you have a question, you can answer.
Okay, sir, I think this is a picture of small bowel obstruction.
Yes. So it's a plain abdominal X-ray of a small bowel obstruction. So mention two abnormalities that are noted.
Central location and vulvulate conniventous, I think.
Yes, excellent. Now you can see this bowel is located one, and there are multiple air fluid levels. Multiple air fluid levels, and you can see vulvulae conniventous. Now, what view is this? This is an erect view, and the most important feature you are looking for in the erect view is what? Multiple air fluid levels. So what are multiple air fluid levels? Who can tell us? What are multiple air fluid levels? Yes?
Yes, sir. So when you have more than 3 air fluid level.
3, we call it multiple air fluid. When there are more than 3, you call it multiple. This one, you can see this is 1. Okay? This air, this fluid. 1, this 1. This 2, there is air and fluid. This 3, air, fluid. 4, 5, 6. So multiple, what are the cardinal features of the condition?
The cardinal features will be vomiting, abdominal distension, abdominal pain, and constipation.
Yeah. Now, for small bowel obstruction, how do they present?
For small bowel obstruction, they present with abdominal pain, constipation.
How does it differ from large bowel obstruction?
So the abdominal distension presents more early than large bowel obstruction. So it's more of abdominal. So it's more of abdominal pain, vomiting, and abdominal pain, vomiting, and abdominal distension.
No, we are not clear. Which one presents early?
In
vomiting
early small bowel obstruction, and late is a late sign in large bowel obstruction.
Yes, that is excellent. Yes, this is another picture. What does the picture depict? Who will participate? Who will answer?
So this is barium meal depicting gastric outlet obstruction, probably pyloric stenosis.
Okay. What is the difference between barium meal, barium swallow, and barium meal and follow through?
So barium swallow, it's meant to depict the esophagus, while barium meal goes into the gastric level. Then barium follow through, pass through up to the intestines.
So which one is this?
So this is barium follow through.
So this is barium meal and follow
through.
You can see it has outlined the stomach as well as the small intestine. However, yes, look at this arrow, is depicting that there is a stenosis.
Yes, sir.
Stenosis at the level of the pylorus. So
yes,
it's the gastric outlet obstruction.
Sir. Thank you, sir.
Yes. So, and because it is a partial obstruction, that's why you can see the contrast is moving into the intestine. So this is barium meal and follow through that is depicting a gastric outlet obstruction, secondary pyloric stenosis. So what investigative modality is this? We've already answered that. Mention 5 electrolyte abnormalities seen in the condition. Mention 5 electrolyte abnormalities seen in the condition. Who can attempt?
So in this condition, there will be hypochloremia, hyponatremia, hypokalemia. There will be metabolic acidosis.
Is it acidosis?
Metabolic alkalosis, sorry, metabolic alkalosis. With
alkalosis. With what?
With paradoxic aciduria.
With paradoxical aciduria. So those are the electrolyte abnormalities. So it is your task now to all go and read about how these electrolyte abnormality come about, because we've discussed them before, how they all develop. So I think we are going to take a break. Then we will come back and continue. We still have a lot to cover. When we cover the, what do you call it, the after the picture test, we are supposed to answer about 50 MCQ questions. Okay, about 45 to 50 MCQ questions. So now we are going to take a break and we'll be back in the next video.
Thank you, sir.
Thank you, sir.
Sorry, sir. Sorry, sir. Excuse me, sir. What time are we coming back?
We are coming back in the next 15 minutes.
Okay, thank you, sir.
Okay, sir. Thank you, sir.
You can make your contributions. Okay, what does the picture depict? Okay, who can answer this? Yes.
Yes, sir.
Yes, what does this picture depict?
So it depicts an erect chest X-ray,
Okay.
showing air under the diaphragm on the left, on the right side.
Yes, it's an erect chest X-ray showing air under the right hemidiaphragm. Okay, so you can see the next question says, mention two abnormalities. So what are the abnormalities seen on this radiograph?
Yes, sir. The air under the left hemidiaphragm, and also there is a homogeneous ground glass appearance.
Of course, there is air under the right hemidiaphragm, and there is a ground glass appearance in the abdomen. Okay, which suggests what? What does it suggest?
Sir, it suggests viscous perforation.
Yes. So what are the differential diagnoses of a patient presenting with air under the diaphragm? So mention three differential diagnoses.
Sir, it could be a perforated duodenal ulcer, perforated gastric ulcer, and a perforated typhoid ileal perforation.
Okay, it could be a typhoid ileal perforation. It could be a perforated peptic ulcer disease, and it could also be perforated even gallbladder.
Yes, sir, gallbladder.
Yes, sometimes it might even be a post-laparotomy, post-laparoscopy patient. Gas-forming organism, abscess, and so on. Okay?
Yes.
Now, what is the immediate intervention in this patient?
So the immediate intervention is resuscitation, sir.
Yes, resuscitation. This patient is immediately resuscitated, because if you are to classify this condition for operation, under what class will it fall into? Is it an emergency? Is it an urgent? Or is it an elective?
It's an urgent, sir.
It's an urgent. It requires resuscitation to stabilize patient before surgery. Okay? For an emergency or immediate intervention, patient is rushed to the theater. The surgery is part of the resuscitation. But for urgent, there is room for resuscitation. And for patients with generalized peritonitis secondary to the perforated viscous, you have to resuscitate that patient, ensure patient is making adequate urine. Okay, you give antibiotics, you give analgesics. Okay, if there is any electrolyte derangement, you correct. If there is anemia, you correct. Okay, before patient is taken for laparotomy.
Okay, sir.
Now we can mention 5 uses of the instrument. 5. Yes, 5. Okay, let me make it 10 since 5 is too small. I know 5 is too small, that's why you are quiet. Okay, mention 10 uses of the instrument. Who will attempt?
I can try for urethral catheter. Hello? Good afternoon.
Yes, what are the uses?
Okay. So you to use to monitor urine output.
Monitoring of urine output, yes. One.
Also for the collect to monitor to drainage draining of the bladder.
Okay, to
Or
pass.
to know if it contains, sir.
Yes, go on.
That's checking it to know if like the color of the urine basically, and check contents of the urine that's coming out.
Okay. One, to monitor urine output. That is the only one I accepted for now.
Okay. Also, for it's used during surgery. Probably to empty the bladder during surgeries. Emptying of the bladder in case of urinary retention.
Okay, that is a different. When you say to relieve urine retention, is different. To empty bladder during pelvic surgeries is also, because if you are doing surgery in the pelvis, you want to what? Empty the bladder to prevent injury to the pelvic structure. Of course. What again?
During shock, to monitor our fluid, the fluid intake.
You've already mentioned monitor urine output. Still the same. That is only now.
To deliver cytotoxic drugs to the bladder. Like cytotoxic drugs to the bladder.
Administer intracavitary chemotherapy. Yes, what again? Catheter.
Continuous bladder irrigation.
Can I try, sir?
You said 10 and we are just getting only 4.
After you
For continuous bladder irrigation.
When?
During surgery.
You see, for 3-way catheter, this is a 2-way catheter. For 3-way catheter, you want to what? After prostatectomy or in patient with pyuria, you want to do a continuous bladder irrigation with a 3-way catheter. Okay, generally, the use of urethral catheters. One is to what? Relieve urine retention, whether acute or chronic urine retention. You want to relieve retention with urethral catheter. If the relief of retention failed via catheterization, you pass suprapubic what? Cystostomy. You do a suprapubic cystostomy and pass the catheter. Okay? And you should know that relief of retention for acute and chronic is different. For acute, you can release, the relief is sudden, you pass, while in chronic is gradual. 2, to monitor urine output. 3, you want to use it as a stent, maybe after urethroplasty. Okay? 4, during prostatectomy, you want to use it to tamponade the prostatic fossa, to fill the balloon with water to tamponade after enucleating the prostate. Is that also? You can also use it as a drain. Okay, you can use it as a drain. It provides drain, soft drain, either open or close when you connect to a collecting bag. You can use it to secure hemostasis in patient that is bleeding from the posterior nasal cavity. You can pass this and inflate the balloon. You can wrap with adrenaline soaked gauze, pass, inflate the balloon, and it tamponade epistaxis. You can also use it, you know, the gyne people, when they want to do a myomectomy, they can use it to secure hemostasis. Okay, you can use it for several other non-conventional use. But basically, you know that urethral catheterization is to relieve retention, is to monitor urine output. You can use it to administer drugs for chemotherapy into the bladder. You can use it to administer contrast if you are doing some investigation like RUG, okay, and so on and so forth. So you should know indications. Now, who can identify these instruments? Yes, what is this?
Yes, this is a Jolis retractor.
A Jones retractor. Jones of Jones retractor for which surgeries? Mention
for thyroidectomy.
Thyroidectomy and what other surgery? The question said mention 2 procedures it is used for. Yes, thyroidectomy. What again?
Tonsillectomy.
No. Tonsil is in the mouth. You open the mouth. This is in the neck. What other surgery you use this for? Okay. After which gland is close to the thyroid gland, posterior to the thyroid gland?
Parathyroid.
Okay. Excision of the parathyroid is called what?
Parathyroidectomy.
Parathyroidectomy. So you use it not for only thyroid. You can also use it for excision of the parathyroid gland also. So the thyroid, mainly the Jones retractor, is used mainly for parathyroid, for thyroidectomy. Now, what is a suture? Who can define a suture? Who can define a suture? Yes. Who can define a suture?
A suture is a material that is used to hold tissues together.
Yes, a fair attempt. This is an oral question. A suture is defined as a strand of material for what approximation of wound edges or ligation of blood vessels. Suture, you use suture for approximation of wound edges or for ligation of blood vessels. Who can mention 5 non-conventional uses of suture? 5 other uses of suture. I've already mentioned 2. Use it for approximation of wound edges. Use it for ligation of blood vessels. Yes, 5 other uses of suture.
It can also be used to anchor drains.
It can also be used to anchor drains. Yes.
It can be used for a stay suture.
It can use it. You can use it for what?
Stay. Apply stay. Stay suture, sir.
As a stay suture. Yes, a stay suture.
It can also be used to mark the site of incision.
You can use it to mark the site of incision, especially during what?
During thyroidectomy.
During thyroidectomy. Yes, what are you using?
It can also be used to tag a specimen.
Seton, sir.
You can use it to mark a specimen. Yes?
Seton drainage, sir.
You can use it as a seton. Good.
Yes, sir.
So these are several uses of suture. Who can tell us the properties of an ideal suture? Properties of an ideal suture.
An ideal suture will be cheap, easy to use, affordable, available, should be inert, should not be interfering with the physiological with the physiology of the patient, and that's what I think. Should have a good should have a less memory.
Okay.
And
Okay. An ideal suture should be sterile.
Yes.
An ideal suture should be inert.
Yes.
An ideal suture should have a low memory. An ideal suture should have a high tensile strength. So who can tell me what is the memory of a suture? When you say memory of a suture, what does it mean?
A memory of a suture is its ability to recoil back to its initial position after deformation.
What do you mean recoil?
Return to its normal position.
Return to its normal position after deformation.
Appropriate term is the ability to unknot. You know, you don't just coil suture, you knot them, you form knots.
Yes,
after you form a knot of that suture to unknot to regain its former state, that is memory. So the higher the memory of the suture, the higher what?
The higher the memory, the higher it's go back to its usual state, the first state. So
Down.
Yes, sir.
Because if it's unknot when you knot, it's unwinds itself, it will open the wound, or the bleeding, the blood vessel will loosen and bleed. Okay. What is the tensile strength of a suture? Yes. What is the tensile strength of a suture? The ability of that suture to withstand breakage. Okay, that is higher tensile strength. When you say tensile strength of a wound, is the ability of that wound to withstand disruption. Okay. Now, what is the relationship between the length of a suture and the length of a wound?
The ratio of all this one should be twice the length of a wound.
Is it twice?
4:1.
No, 3, sir. 3.
4:1.
Okay,
4:1. Identify. What is this?
Sir, this is a child with hemangioma, sir. Capillary hemangioma.
That is excellent. It's a child
Yes,
with
sir.
hemangioma. What are the types of hemangioma?
Sir, the types of hemangioma.
We have the capillary, the cavernous.
Capillary, cavernous.
Yes.
And mixed.
And mixed.
And mixed.
Yes.
Mixed. Okay, sir.
So,
Okay, sir.
what are the modalities of treatment?
So you can excise the, you can inject a sclerosant.
So, excision with ligation of the feeding vessel.
Yes. Yes, sir. Then injection of sclerosant.
Sclerotherapy, yes.
Sclerotherapy, sir.
What again?
Use of laser to excise the liver.
Treatment, radiotherapy, what
Radiotherapy.
cryotherapy.
Cryotherapy.
Are the phases of hemangioma.
Okay, sir.
The phases hemangioma passes through. What are the phases of hemangioma? There's a phase of proliferation. Okay? There's a phase of what? Proliferation. There's a phase of involution. And the third phase is involuted. That's why hemangioma, you have to what? Commence a non-operative treatment, because they might undergo what? Involution. So you have to allow them for about 3 to 5 years. Okay? So we will undergo involution. Not that a child just presenting with hemangioma, you just go and excise. You allow them commence non-operative treatment. And subsequently, when they might just disappear. Identify. What is this?
A child with a cystic hygroma.
Cystic hygroma. Okay.
Yes, sir.
What are other names for cystic hygroma? Mention
Lymphangioma.
3 other names.
Lymphangioma, sir.
Lymphangioma, yes. Another name?
Lymphangiosarcoma.
No.
Hydrocele of the
Hydrocele of the neck, yes.
Okay.
One more. Okay, we've mentioned 3. We said what the first one is what?
Cystic hygroma.
We said lymphangioma
And lymphangioma
of the neck. Okay, now what is the pathogenesis of lymphangioma?
So the pathogenesis of is the failure of the lymphatic channel to coalesce together to create a channel. So there is so in that case,
and distal obstruction of the lymphatic channel, and a segment of lymphatic channel is intestinal, not draining into the mainstream lymphatic channel. So it continues accumulating fluid until it forms a swelling. Okay?
Yes, yes, sir.
Trapped segment of lymphatic tissue that is not communicating with the mainstream. What are the sites you can find?
The other sites are good axilla, groin, mediastinum,
the tongue,
yes.
Now you should know 75% of cystic hygroma occur in the posterior triangle of the neck.
Okay, sir.
75% of lymphangiomas or cystic hygromas occur in the posterior triangle of the neck. And the complications of cystic hygroma could include what?
It can compress on the respiratory system to cause respiratory embarrassment, difficulty in swallowing, sir.
Symptoms, pressure,
and ulcerate, pressure symptoms, sir. Yes, sir. It can ulcerate and bleed, got infected.
It can become infected.
Yes.
Now, when you have lymphangioma, what can it lead to?
Didn't get him right.
Now, it can cause. You should also remember these are among the swellings that brilliantly transilluminate light. Okay.
Yes, sir.
Identify. What is this?
Cleft palate.
Cleft lips and cleft palate.
Yes, cleft lips and palate. Mention 4 problems associated with this.
Difficulty in feeding.
Cosmetics.
Okay, cosmesis, yes, 1.
Aspiration problem.
Okay, sucking. You, why don't you start with food? You have to eat to survive.
Failure to thrive.
Yes, they cannot feed, they cannot suck, they cannot intraoral pressure during suckling. While suckling, they might aspirate. Is that not so? Yes, this will lead to recurrent chest infection, failure to thrive, malnutrition, okay? Difficulty in what? Pitch. Especially what alphabet? What alphabets? Difficulty in pronouncing
B.
what?
L.
What do you call the group of alphabets that they are difficult?
Alphabet B and C.
Nasal alphabets.
No, is it the consonant? Not the consonant, the vowels.
No? What do you call them?
The labial, okay. The consonant, sir.
Which
The consonant.
Name, the group of names you call this.
The labial one, sir.
They are called the high-pitched consonant. High-pitched.
Okay. High-pitched consonant. Okay, sir.
Like B, not labial alone, because yes, the high pitch you use your lips to pronounce.
Okay, sir.
P. Okay, they are called the labial consonant.
Okay, sir.
So you should know all the problems that are associated with this. I'm going to share a slide that have all the details of this. Identify, okay, what is this?
It's an abdominal X-ray with
okay, double bubble sign.
Yes, this is a plain abdominal X-ray showing a double bubble
sign.
So what is the likely diagnosis?
Duodenal atresia.
Duodenal atresia.
Yes, sir. Sir?
How does duodenal atresia present?
Sir, they present with the features of intestinal obstruction.
Bilious vomiting.
Bilious vomiting, early vomiting. But because it is upper, there is not likely to be abdominal distension. So there is constipation as well.
Okay. Yes, now you see the bilious vomiting, it depends on the position.
Location.
Yeah, the location. Whether
yes,
the ampulla or so this double bubble, this first bigger bubble is what? This bulb here, this bigger one is what?
Stomach.
Yes, it's the stomach. And it's the duodenum. So what is treatment? What is the surgical treatment?
Yes.
What is the surgical?
Duodenostomy.
Duodenostomy. Okay. Identify.
Keloid.
Keloid. 3 reasons for your answer.
The race is more prominent in black race or black people.
Yes, the race, you can see the color of the individual.
Lobulated. It grows outside of the margin of the wound.
It grows outside the margin of the initial scar, yes.
And it's lobulated.
Location.
Lobulated is not a reason. The location is common in the earlobe. Generally, head and neck region, the sternal area. Yes, what other reason?
It grows more prominent in women than men.
The sex.
Yes. So, what are the differences between keloid and hypertrophic scar? Let's mention 10 differences between keloid and hypertrophic scar. So let's mention them. 10.
Keloid remains within the boundary of the wound. Hypertrophic goes beyond the wound.
No,
keloids have a genetic predilection.
No, you are starting on the wrong.
No. It was interchanged.
Come again.
Yes, sir. I said the keloids, they go beyond the wound margins. Hypertrophic scar does not.
Yes. One, that is one.
There is a genetic predisposition in keloids, while in hypertrophic scar there is none.
2.
Then keloids have a racial predilection on blacks, while hypertrophic scar does not.
3. That is excellent. 7.
Keloids are commoner than hypertrophic scar. Oh, sorry, hypertrophic scar are commoner than keloid scar.
I don't agree. What about the age of the patient?
Keloid is more prominent in young people.
And then hypertrophic scar can be at any age. There's no age boundaries.
Hypertrophic scar doesn't have age predilection. Why keloid is commoner in adults? That is 4.
Yes.
4 or 5? 4. 6 more.
Keloid is more common in the face, the trunk, while hypertrophic scar can occur in any part of the body.
Yes. 5. 5 more differences.
Hypertrophic scar can regress, while keloid will not regress.
Yes.
Yeah, keloid not respond to local or topical treatment. Hypertrophic respond to topical treatment. Yes. What again?
So there is high risk of recurrence in keloid.
There is higher risk of recurrence. Yes.
And
what of a relationship to the collagen?
In keloid, the collagen fibers are random, while in hypertrophic scar they are parallel.
What types of collagen are in keloids? What types?
Keloid is a type 1 collagen.
Yes.
It's type 1 collagen, sir, in keloid.
No. Collagens, you know.
Type 2?
No, you are guessing now. Collagen, remember, base. Okay. Or let me give you a minute.
Type 4 is basement membrane. Type 3 is.
Type 4 is what?
Type 4 is found in the basement membrane.
You see, this is skin. Type 2, connective tissue. Connective tissue, type 2. Type 3, you have what? Arteries. And type 4. So these are the 4 common types. Okay. Now, when you see a lot of thick type 3 collagens, you know wound still in the proliferating phase. When they are maturing, most of the type 3 are being converted to type 1. Okay? So you have a lot of mature type 1. So you have a lot of thick type 3 collagen. Yes, identify.
Hydrocephalus.
Mention 5 features of raised intracranial pressure. Mention 5 features of raised intracranial pressure.
Vomiting, convulsion,
Bulging of anterior fontanelle.
tense anterior fontanelle.
Sunset eyes.
Okay.
Head face disproportion.
What are features?
Irritability.
Vomiting, sir. Vomiting.
Convulsion.
Projectile vomiting.
Convulsion.
I've written on.
Headache.
All this while I collected, I just dropped it. Now
What type of vomiting they have? What type of vomiting?
Projectile vomiting.
Projectile.
That time of the day.
Early morning.
Early morning.
Why is it early morning?
I don't know.
Sensation of
Early
care.
morning.
Case of MRSA, as you add it to the previous case report, then you become 3, right? And publish as a
Early
case.
morning projectile vomiting, headache. Okay, what again? For children, you know, headache will present as irritability, unconsolable.
Yes.
Okay, for children, they have bulging of the fontanelle, sunsetting eyes. Okay, what again?
Head and face disproportion.
No, you know, the question I asked is raised intracranial pressure, not hydrocephalus. Features of raised intracranial pressure.
Convulsion.
Yes.
Polydactyly.
Okay, this is polydactyly. What is it?
Surgery.
What do you mean surgery? You do surgical.
Amputation or excision of the excess ligature.
A 25-year-old male, identify what
Gynecomastia.
Bilateral.
Okay, bilateral
gynecomastia.
What are the causes?
Drugs, liver problems.
So
genetic.
It could be physiologic.
Metabolic could be
physiologic or what? Pathologic.
Pathological.
Now the physiologic are 3 types. What are the physiologic?
Neonatal.
Neonatal. What again? Pubertal. And what? Senile. Okay. This is seen in the neonatal period, puberty, and elderly. Now the pathologic types.
Metabolic.
Metabolic from what?
Increased estrogen.
From what?
Decreased estrogen from liver disease.
Estrogen, progesterone imbalance.
Liver disease. Drugs, like what drugs?
Digoxin. Spironolactone.
Yeah. Again, we've mentioned drugs. What again?
It can be as tumors.
Digoxin, marijuana.
Marijuana. Yes, what other pathologic condition will cause gynecomastia?
Chromosomal abnormality.
Like which one?
Klinefelter syndrome.
What
could be idiopathic.
It could be idiopathic.
What of thyroid disease?
Thyroid disease, like which one?
Hypothyroidism.
Hypogonadism.
No,
but it should be
hypothyroidism.
No.
Hypothyroidism. Hypothyroidism.
Hypo.
Not hyper.
Hyper.
No, not common.
Plasmatia is hyper and then decreased libido as well, I think.
It's uncommon with thyroid diseases. Yes, what again?
Cushing's disease.
Cushing's disease.
Cushing's syndrome.
Okay. What investigative modality is this?
Urogram, I think.
Urethrogram.
What is this?
Cystoscopy.
Urethrogram.
What is RUG?
Retrograde
uretrogram. Retrograde uretrogram. What you can see what condition is it used to diagnose?
Obstruction. Urethral obstruction.
Anterior urethral.
It's urethral. What is urethral stricture? Who can define urethral stricture?
Narrowing of urethra.
No.
It's a non-distendable segment of
who can define urethral stricture? Urethral stricture is defined as narrowing and loss of distensibility of the urethra. It's not only narrowing, there is loss of distensibility. Mention
Yes, sir.
2 treatment options for urethral stricture.
Resection
and anastomosis of the segment.
Okay.
Ureterectomy.
There could be resection and anastomosis and what?
Direct visual internal ureterectomy.
Okay. So the anastomotic uretroplasty, when you have short segment, you just resect anastomose. Then you can do another. When it's a long segment, what will you do?
The substitution uretroplasty.
Uretroplasty. What investigative modality is this? Yes?
Barium swallow.
Barium swallow.
Mention 2 conditions used to diagnose.
You can use for
achalasia.
Esophageal spasm.
Esophageal corrosive esophagus.
Diverticulitis.
Esophagus.
You always start with common things. Common things.
Esophagus.
Barium.
Stricture.
Achalasia cardia. So who can tell me, how do you differentiate achalasia cardia and esophageal cancer from history? From the history.
So in terms of achalasia cardia, the patient will have difficulty in swallowing. Firstly, difficulty in swallowing in liquid, then to solid.
That is, and it is intermittent, sir, as compared to cancer, which is progressive.
Progressive, yes, okay, sir.
So which one are you answering? Take it one after the other. Don't confuse me. What is the difference between and
progressive dysphagia in cancer?
Yes, in carcinoma they have a progressive. Why in achalasia, what do they have?
Intermittent.
Intermittent. That is one. What of the duration?
The duration is short in cancer.
It's shorter in malignancy. Very long duration in achalasia. Yes. So that's how you differentiate. Again, what of the dysphagia?
Yes. It's first to solid, to liquid, then to solid in achalasia.
Initially is to liquid, then to solid.
To solid, yes. Why
in carcinoma?
It's initially to solid, then liquid, then
yes. Even though sometimes it can be difficult to differentiate. What clinical condition is this?
Dural hematoma.
Subdural hematoma.
No.
This is
epidural hematoma.
You have to give a complete diagnosis. Epidural is not a complete diagnosis.
It's a left parietal epidural hematoma.
Not complete.
Right.
Acute epidural.
Acute. That is the word I'm looking for.
Yes, sir. Acute.
Acute what?
Left-sided.
Right-sided epidural hematoma.
This is the anterior, this is the posterior.
Acute left-sided epidural hematoma.
This is the right. So you can see, why is it acute?
Because it's hyperintense. Hyperdensity.
Because it is hyperdense. You can see the density is similar to that of the cord, so it's hyperdense. Okay, so that's why it's acute. So why is it epidural?
Because it is by convex in shape.
By convex.
Convex. Excellent. Okay. Mention two abnormalities you mentioned.
There is midline shift.
Midline shift. What again?
There is loss of sulci and gyri.
There's loss of the sulci and gyri. What again?
Left ventricular ventricle. The ventricles are obliterated.
Obliterated ventricles. Excellent.
And then perilegional edema.
Yes. Perilegional
edema.
Mention a unique feature in the clinical condition. What?
Lucid interval.
Lucid interval.
Who can define lucid interval?
Lucid interval. It's
Who can define lucid interval?
Is a period of time when the patient feels fine and doesn't have any complaints.
What do you mean feels fine? I have money.
Sir, is defined as a period of consciousness between two
unconsciousness.
Following unconsciousness.
Feels fine. Because me, if I have money in my pocket, I feel fine.
The lucid interval is a period of consciousness following prolonged unconsciousness.
Okay. So is that period of awareness in between two episodes of loss of consciousness? The initial loss of consciousness is at the primary brain injury, the primary impact. Okay, patient lose his consciousness. So then he now regain consciousness. Okay, but you remember he has already sustained an impact. Blood keeps on accumulating. It gets to a level of increase, okay, intracranial pressure when the blood accumulates. Then the secondary brain injury leads to the second loss of consciousness. So that period of awareness between the two episodes of loss of consciousness. And is this classical of what? Epidural or extradural hematoma. What is the diagnosis here?
Subdural hematoma.
Chronic.
Calm down, guy, calm down now.
Left chronic subdural hematoma.
Left-sided chronic subdural hematoma.
Chronic left-sided subdural hematoma.
Why is it chronic?
It's a hypodense lesion that was seen.
Hypodense. Why is it subdural?
And it's lenticular, that is lunar-shaped lesion.
Centric.
Concave. Yes.
Mention two abnormal. Mention two abnormalities.
But there is lots of sulci and gyri.
Yes.
And then
in which part?
Effacement of ventricles.
There is a tissue.
Factual deviation. Effacement of the ventricles.
Okay, identify.
Tracheal tubes.
This cuffed and uncuffed.
Yes, this is the cuffed one. This is the cuff here. And this is the you know, this is used for children, okay?
Yes, sir.
This is used for adults. So mention two indications for using this instrument.
To secure airlines.
Yeah, surgery.
Yes, what?
General anesthesia, to secure airway during general anesthesia in surgery.
You see, you mentioned two at a time. Securing an airway in an unconscious patient is an indication.
Yes, sir. administration of an anesthetic agent to the patient.
Another indication.
Also, you give oxygen.
Yes.
This is loop colostomy.
This is a loop colostomy. Why did you say it's a loop colostomy?
It's two openings.
There are two openings.
No, that is not the reason.
There is no breach of skin.
There's no skin.
There is no skin.
And it has one stoma.
This another opening. It's not one stoma. It has two openings, but there is no skin breach.
Yes.
That's why it's a loop. You can see continuous intestine between those skin breach. Okay. Mention two other types.
Divided colostomy, which we have double barrel colostomy.
And what?
I can't remember the
And
other one.
colostomy.
And colostomy.
And colostomy. The divided are two types. You say double barrel and what? Divine.
And divine colostomy.
Those are divided. You could have end colostomy. Mention 4 complications.
Can prolapse.
Colostomy. Please, the more you talk, the better.
Colostomy diarrhea.
When you see
Paracolostomy herniation.
Hemorrhage. Colostomy failure.
Infection. Colostomy failure.
Infection.
Flap colostomy necrosis.
Colostomy prolapse.
Herniation. Stenosis.
So now the colostomy, you know, the complications could be related to the tumor itself or the surrounding skin. Is that not?
Yes, sir.
So there could be prolapse.
Yes,
there
sir.
could be retraction. There could be stenosis. There could
Yes,
be
sir.
there could be paracolostomy hernia.
Idea, yes, sir.
There could be skin excoriation. There could
Skin excoriation, yes, sir.
What is this?
Plastibel.
What is it used for?
Circumcision.
What are the indications for circumcision? Mention 5 indications.
Cultural,
I said
religious.
5. Yes, for cultural reasons.
Recurrent urinary infection. Phimosis. Is it phimosis?
Are you
Phimosis.
asking?
Are you asking?
Yes, sir.
Cultural stroke religious reason.
The medical.
Meatal stenosis.
Meatal.
Periphyseal glandular adhesions. Periphyseal growth. Balanitis, recurrent post.
Phimosis.
Paraphimosis. What again?
About
Periphyseal glandular adhesions.
Yes, phimosis.
Osmosis.
What are the complications of using this instrument?
Retention. We can retain.
Okay.
Hemorrhage. Infection. Stenosis.
Bleeding, there could be
Bleeding. And
infection.
An injury to the gland penis.
And it can fall off early.
Mention 4 precautions using this drug.
Patient must be making adequate urine.
Patient must be making adequate urine, yes?
Patient
Should be under ECG
monitoring.
Under ECG monitoring, yes?
Should not be given bolus.
Not be
should not be given bolus.
And that
Urine output monitoring.
The rate of infusion, you should not be given 20 millimole in more than 1 hour or 40 millimole in
and having calcium gluconate, for example.
No, we said the rate of infusion should not be
more than 120 millimoles per day or 40 millimoles in 1 liter or 20 millimoles in 500 ml of saline.
or 20 millimoles per hour. 20 millimoles per hour. So now we are going to proceed to the MC. In fact, this is the most important aspect, okay?